This production was made possible through a grant from the Richard M. Fairbanks Foundation.
The following is a co-production of Side Effects Public Media and the Indiana Minority Health Coalition. The impact of the opioid epidemic on minorities in Indiana.
Hello and welcome. My name is Carmel Roth. I'm the managing editor of Side Effects Public Media, WFYI's public health journalism initiative.
And I'm Tony Gillespie, Vice President of Policy and Engagement with the Indiana Minority Health Coalition. Thank you so much for joining us.
In February, Side Effects joined with IMHC to host a conversation about the opioid epidemic and how it impacts communities of color in Indiana.
We welcomed an esteemed panel to WFYI studio to engage in a discussion, followed by questions from viewers throughout the state watching through a video stream. We received many thought-provoking questions and comments after the panel conversation, and we'd like to share some of that conversation with you.
It has been edited to fit our WFYI time slot. Nevertheless, we hope you'll learn something new from the panel just as we did. All Hoosiers are impacted by this national epidemic, and it's important not to overlook its effect on minority communities.
Panelists included Ronald Sullivan, Jr. of Harvard's Criminal Justice Institute, Joselyn Whitticker, a community leader living in Grant County, Indiana, Brad Ray with IUPUI School of Public and Environmental Affairs, and Jocelyn Bush, a medical doctor specializing in pain management. The discussion was moderated by local business consultant Michal Twyman. The conversation begins with the panel unpacking a recent startling quote from a New York legislator concerning the opioid crisis.
So let's open it up, and I'm going to actually direct this question to you, Ronald. We had a state senator in New York that said it's not a ghetto drug. It's happening to doctors' kids. In the context of our discussion today, what's your reaction to this notion that it's not a ghetto issue or something that's manifesting itself in the ghettos of our community, but this is happening to doctors' children?
Well, it's a very clear sign to my thinking of the way criminal law is practiced and has been practiced in the country for a very long time. That is to say, the African American community has had an epidemic with respect to drug addiction of a certain type of drug for a very long time. The vocabulary was consistently criminal. When other communities began to experience addiction, then the vocabulary changes quite dramatically to a medicinal vocabulary. That is, treatment is the first stop. Now, I think that's the correct vocabulary and that all communities should be treated like this. But it is quite consistent with the way in which criminal law is practiced. And it's for the following reason. So one scholar puts it this way. He says that we ought to localize criminal law. What does he mean by that? He says that the people who tend to make the statutes, that is the laws that govern the criminal courts, the impact of those laws tend not to impact them, their children, their nieces, and their nephews. Because if it did, they wouldn't write them in such a draconian fashion. This is a prime example. When the scourge of drug abuse began to creep its way into certain communities and people began to be impacted by them, then their consideration of those things changed. It's no longer this vicious criminal thing that needs to be dealt with. Instead, it is a medical issue that needs to be dealt with in treatment. So hopefully the country is learning from this, has learned from this, and will begin to treat drug addiction for what it is, a medical issue.
Other reactions from our panelists around both the quote and comment or this notion of maybe things only being public policy or becoming issue or crisis when they affect a certain segment of our population?
In reality, since I have been a lawmaker and a city council person, I've seen that work. And if you look at the state legislature and so on, if you look at how we deal with the issue of overdoses right now with the opioid problem and how we deal with 3 strikes and you're out for marijuana, there is a huge gap because the person who is overdosing is taking an illegal drug. Yet we revive them and let them go on their way. The person with the marijuana, we lock them up. Go to 3 strikes, they go for life. And usually that affects the Black community or the minority population than anybody else. I raised this question recently, probably 2 weeks ago, at a town hall meeting. The question was not addressed. The reality is, when Blacks were taking heroin in the late 70s and the 80s and so on, it wasn't a crisis because it was in that community. Since it has become a majority community issue, there is a crisis in this country and how we will deal with that. Yet, we still have not gotten our legislative body to understand how that impacts, because we still have people who believe there's no racism in this country. So with that in mind, how do you deal with a situation when you look at how people are sentenced in the state of Indiana and this country? You start to see the disparity in itself.
So there's, throughout the criminal justice system, as you're alluding to, there's just structural racism, right? So African Americans, whites have no difference in their likelihood to use or abuse drugs, but if arrested, more likely to be arrested. If arrested, more likely to be sentenced, and if sentenced for harsher punishments and further time, right? So this is throughout the entire criminal justice system. And I think one thing I think we'll probably talk about in a bit, but as this epidemic did start out, largely a white epidemic, it has moved into African American communities. And so I think one of the most frightening aspects about using the criminal justice system to address this problem to me is that it would disproportionately affect African Americans to use a system that already has such structural, racism embedded in it. So I think that's one of the bigger concerns, that as we see this moving into African American communities, using the criminal justice system could be potentially problematic.
Ronald, do you have some insight on that too, the whole criminalization of the issue?
It is true. The data show that Blacks and whites don't use drugs in any appreciable difference. They use it at about the same amount on a per capita basis. However, African Americans represent over 60% of people nationally who are incarcerated for drugs. That alone should at least make policymakers and legislators begin to think about the way in which the reach of the law is impacting communities differentially.
This issue of access and use relative to both illegal and legal drugs, speak both historically and what you see in terms of maybe racial overtones to how that's looked at.
I mean, historically, if you look at some studies, they show that for whatever reason, medical professionals might have some prejudice towards minorities, and that minorities were traditionally either thought that they didn't experience pain as much as whites, or that they would misuse or abuse the medications such as opiates, right? So they weren't given opiates, and white patients were traditionally given this. And so I guess if you look at the studies and some of the literature, Blacks were sort of insulated from the initial phase of the opioid crisis because we weren't given prescription painkillers. But what's happened now is that as we've decreased how much we're prescribing by the CDC guidelines, and we're decreasing the sort of the pill burden that's out there, drug dealers or whatever are now seeing this opportunity to then flood the market with heroin and fentanyl. And so now, because drug dealers don't care about the color of your skin,
Right.
they are now letting or selling to both Blacks and whites. So I mean, I think if you look at, that's why there's the rise in sort of the Black overdoses that are coming now, and it's more fentanyl and heroin and not prescription opioids.
In terms of this issue of shaming and shame, if there is such a thing, I know, Brad, you talked about earlier on one of our discussions that some may see oftentimes use and overuse as a moral failing. Do you think that that's still true, and is that more so prevalent in communities of color versus the majority? And around the issue of it being a moral failure?
Yeah, I think, so one thing, it's difficult to talk about persons of color in the United States without kind of just laying out, that there's been structural inequalities for the existence of our country. So those persist today and really manifest themselves in differences in socioeconomic status. And so I think one of the reasons is we see African Americans having less likely to have insurance. So they're less likely to be getting some of these prescription drugs, as you noted, right? And this is largely due to, as I said, structural inequalities that have manifested in differences in socioeconomic status. So I think when we talk about there being a lens of moral versus immoral, I think it is based around race and ethnicity, but I think it's also based around social class. Poorer people are seen as sort of the more moral failing, right? Because they are unemployed, because they potentially have, persistent mental illnesses, because they have other sort of social barriers around getting treatment. So I think we tend to see those individuals as having moral failings, whereas the person who took too many opioids after they had their dental surgery, their dental event, or who took, interacted with alcohol, those individuals are seen as more having accidents. And then there's those individuals that have insurance that can get diagnosed with opioid use disorder. So then, as you had pointed out, then this is a more medicalized approach to it. So I do think that there are different approaches to this, and they're based on, race, ethnicity, and I think class and access to treatment and services. Right. So,
Jocelyn, would you say that some of the rhetoric maybe around moral failure comes from corners of our faith community?
Most definitely. And I'll give you an example of something that has happened in our community. Grant County has 70,000 plus people. It was so bad in 2017 that I had a white minister tell me, who was a friend, because I worked with and led one praying for Marion and Grant County, because we were having such a huge problem with it. But it was so bad, the parents did not want the obituary to appear in the paper. And as a mother, sister, and so on, I thought to myself, I said, I hope that I never get to that point where I'm afraid or I feel that I'm shamed that my child did something and that would be looked upon as a moral failure for me.
Right.
Because at no point would I hope, get to a point where I would not want to celebrate my child's life.
Others of you want to add to that?
Yeah, I can jump in. The point about mental illness is excellent. Our prisons are filled with the mentally ill. So I think that we as a culture do a very bad job at recognizing aspects of personality that don't fit well within the criminal justice system. So the criminal justice system is too blunt an instrument to be able to deal with many of the social ills that lead to at least a formal violation of the criminal law. So, and oftentimes with forms of mental illness, people self-medicate. And if you treat that criminally, you're not moving down a path of rehabilitation at all. So I think that we have to think a lot more strategically and a lot more creatively about how to push people away from the criminal justice system rather than warehousing people within the criminal justice system.
Yes.
And just to follow up on that, I think a lot of the reasons that the police and law enforcement use jails and incarceration so frequently is it's the one place that cannot turn anybody away, right? So you can take somebody to a treatment provider, they can say, we've had problems with this person before, we don't take people like this, but that's the one place, and there's research showing that when police have a 24-hour, no refusal drop-off location, that they do want to drop people off there. And they will drop people off there. So I think we need to think about when we don't have other treatment options available, that's when the criminal justice system becomes sort of the court of last resort, if you will.
Right.
So.
And not only that, we need to look at training, because my background is education. We need to look at educating and training our police officers how to deal with mental illness, how to deal with drug overdose, and so on. And that is a very scary thought, because nobody would like to admit there's a family member who may be a little odd or different.
And you know, I saw a study recently, and I don't remember the numbers exactly, but it was like, you know, I think over half of these police encounters are with persons. That's like the group that they're most likely to see are persons with mental illnesses. And they did a survey of all these criminal justice programs across the country, and less than 20% actually teach officers. You know, so we're educating officers on all these other components, but the population they're most likely to intersect with, we're not actually teaching them how to deal with that population. And I think that should just be a systemic change across the board in how we're training our criminal justice professionals moving out into the field. So
this segues nicely into my next question about perhaps there being an arc in the opiate epidemic, starting for perhaps prescription of opiates, and in some with use disorder, and then seeking heroin on the street. Are there differences for how African Americans and other racial and ethnic groups compare to whites and what happens at various points along the way? So starting from being prescribed to perhaps going to the street in order to get your fix. Can you speak to that, Dr. Bush?
I can address it a little bit, I guess. In terms of like prescribing, like we said, there's, for whatever reason, that bias that might have initially begun where minorities were not given prescription opiates. And so they then, if they were in pain, were then going to possibly seek other avenues to get medication, yes. And then in terms of like, primarily, if you're looking at whites and they were given those prescription opiates for their pain, then they would take them home, right? And so then you have the diversion issues where people were then letting my best friend or my husband had a pain. And then we found that like children, and that's sort of how it sort of progressed to the children of the doctors are getting prescribed or getting, addicted to these medications. And the arc might be that in that regard, that they had the medicines at home, that they could use them and then get addicted and get abused in the wrong way. Because clearly they're not taking them for pain. They're taking them, as we talked about, for mental illness, whatever, or because they want to fit in, or because they think this will make them not care about school or not care about whatever relationship issues they're having. And then I think, as we said, just going back to the bias, it's easier for them to get them again. And I think experienced prescribers, right? So I'm a pain physician. I'm experienced in prescribing my medications. I see my patients monthly. I'm gonna like evaluate them. I'm gonna make sure they're appropriate, they're taking their medicines appropriately. I'm gonna look at their inspect report, which shows when they fill their medication, and we're gonna count medication as well. We're gonna do urine drug screening. Some providers don't even have the ability to do that because of busyness, because they have such a large patient load, or because they're not even skilled in terms of knowing how to prescribe opioids in the correct way. And so then they're saying, Joe Schmo called in for a refill, well, I'm gonna give him another one because they've been a good patient. And it sort of just continues like that. So.
And I do think that there has been, we described this earlier, as kind of an arc over time. Like we're saying, like initially we saw this as individuals. And I think that arc largely goes across socioeconomic status lines, right? So initially, individuals who had insurance were getting these medications. They were abusing them, and we've seen this sort of change over time. One of the things we've done here to get to the INSPECT, so the INSPECT is for those of you that don't know, it's our prescription drug monitoring program. So doctors input information on patients and can check the information on patients that have had scheduled substances. And so we've done a study here where we looked at individuals. So we look at all of the cases of folks that died over the past 2 years. And we've seen how many of them have actually had an INSPECT record. Surprisingly, only about half are even in INSPECT, which is illustrative of the point that many are just using illicit substances. And very few people are actually just dying from the prescriptions that are prescribed to them. And that's primarily white females when we look at that group, so dying of just the substances that were prescribed to you. But there is a significant difference in by race and the likelihood to have even had INSPECT. Less than a third of black decedents ever had an INSPECT record in the year prior, compared to about half of white decedents. So there is this sort of disparity, and I think it's partially being driven by access to treatment.
The panelists moved on from access issues to talk about how opioid addiction is evolving. It had been called a white problem. When prescription opioids hit the market in large numbers, they were prescribed primarily to white patients. and opioid use, both legal and illegal, skyrocketed.
But with greater illicit use, plus more powerful street formulas containing the opioid fentanyl, addiction among minorities is rising. Researcher Ronald Sullivan of Harvard cited that data indicates deaths from opioids in the African American community are now comparable to what they were for whites in 2014.
So this is a cross-cultural, cross-racial American problem that we have to deal with. And to the speaker who mentioned fentanyl, that's absolutely correct. That, pardon me, fentanyl is the new game in town. It is extraordinarily dangerous, and the data that we're going to see, unfortunately, I think a year from now, as we look backwards, is going to be startling. So for people who think in epidemiological terms, for people who think in public health terms, this absolutely is a public health crisis that has to be and should be dealt with responsibly.
And part of the reason we haven't seen the fentanyl before now is we actually don't do a very good job of tracking these different types of substances. So when we track the national death data, we have what's called ICD codes for heroin, we have ICD codes for synthetic opiates, but we don't have an ICD code that's specific to fentanyl. And so it's really, that's what people are dying from right now, is fentanyl. And I think we talked about this, and I don't know if you have any additional information on this, Dr. Sullivan, but I think my understanding is most of the fentanyl is coming in from China through our ports.
Dr. Bush, following up on that, it's kind of a three-part question, but any views you have on fentanyl and the use of it and maybe the rise of it, but then two, speak from your practice experience and particularly what you do at the Pain Management Center. What are appropriate circumstances, and I know it's case by case, where opioid being prescribed is the right thing, number one, and then three, a number of other options that are available to patients in terms of managing pain?
Right, so in terms of the fentanyl being on the streets, it's sort of it's an odd thought, because in anesthesia and in pain management, we don't see powder fentanyl, we see liquid fentanyl, or we see it in a patch. And so the fact that it's been purified down into a powder is actually, it's mind-blowingly scary. It is a very strong drug. When we administer it, we give it micrograms, and that's by a nurse or a doctor giving it through the IV, monitoring the patient. That's how quickly it could stop you from breathing and all those things. And so it boggles my mind that people would want to do that.
So highly lethal under uncontrolled circumstances,
yes,
needless to
absolutely,
say. Yeah.
Absolutely. A medical professional needs to administer fentanyl.
Yes.
In terms of other options and sort of why you treat with an opiate, there are many reasons to have pain. There absolutely are. You don't want to treat acute pain that might be a muscle injury or a little sprain with a large dose of opiates like fentanyl, definitely, but Vicodin or Percocet. You might want to start initially with an NSAID, which might be an ibuprofen or a Motrin, or you might want to start with a muscle relaxant, resting, icing. In terms of patients that do get opiates, those are patients who've had major surgery, who are dealing with significant limitations in function due to scarring and hardware, and these people can't stand up, much alone go to work or to do their ADLs, which we call or basically your activities of daily living. These are the things you have to do just to take care of yourself. And so we assess our patients. We don't just say, a patient can't just come in and say, oh, I hurt. No, we're gonna do a physical exam. We're gonna have some history. We're gonna do some diagnostic studies. We're gonna document why you're in pain. And then we're gonna treat you accordingly. We're gonna give you small amounts and we're gonna see how things go. We're gonna have you determine and tell us your pain level, your functionality. How are you doing at home? Are you doing your physical therapy? And that sort of leads me into the other options that we offer patients. So let's say you have a herniated disc and you have pain down your leg or in your arm. We'll start maybe with some medication, but then we're going to say what we need to do after the diagnostic studies is possibly do an epidural injection. And epidurals are things that we do with our interventional procedure that we can place steroid next to an inflamed nerve. And that's not an opiate. That's not something that you're addicted to. And it's going to ultimately improve your functionality. We also have, a number of other injections for arthritis, for chronic pain as it is. We have infusions, but we also have the option that if opioids really are what you need and that you can't sort of manage on the smaller doses that the CDC are telling us that we have to give you, we actually have implantable devices called like an intrathecal pump where you put a catheter in your spine and we control how much opioid you get. And it's 1/100th of what you're getting orally. And there's no way to manipulate it, there's no way to divert it. And that's a way to treat patients with chronic pain.
Excellent. Around this issue of access and going for treatment, a lot of course, we know the patient-doctor relationship. If there is no modicum of trust, meaning the patient presenting themselves in a way that, one, they're truthful, but two, also feeling that the person on the other side of the examining table is going to believe them, going to value them, or even treat them fairly. Does that factor into this equation around this issue at all, the issue of trust and mistrust?
I mean, I think like studies have shown that African Americans have a distrust of healthcare. I mean, they feel like either they're going to be experimented on or not treated fairly, which, like we said, studies have shown that, they're not prescribed opiates to the same degree that non-minority patients are. I think as a physician, when I look at a patient, I don't look at their color. I literally do the same exam on somebody if they're white versus they're black or Latino or Asian. Mm-hmm. I'm going to do the same diagnostic studies. I'm at the same requirement for medical records, for urine drug screening. And I'm going to ask them to do the same things that I'd want anybody with the same condition to do, meaning physical therapy, intervention, psychotherapy. And so it's hard for me to address that, sure, being a minority myself.
Or do you think there are perceptions that people in minority communities, particularly African Americans, have about the system, if you will?
Of course. They have it about all systems. And if you were to talk to the average person who's on the street about Dr. Bush or myself, they're one of those people. But yet, the people who are overdosing in the streets are not seeing Dr. Bush as their physician. Mm-hmm. They are not talking with Joselyn Whitticker or the NAACP or Minority Health about the issues that are coming, that they have. And 9 times out of 10, the person who is dispensing the drug is not a medical doctor. Right. So they're getting it from the pusher on the street. The pusher on the street doesn't know what is in that substance, right, because he got that substance and he is pimping himself out to make money for his family. See, the problem is so complex, and it's very easy for us to sit on this panel and say, hey, you ought to be doing this and you ought to be doing that. But for the person who is on the streets, they perceive us as the establishment, here you go again, telling me what to do.
Dr. Sullivan, you're nodding your head. Could you also maybe just speak to what's the appeal on the street? What draws people and what keeps not only the market going, but this whole issue of gotta feel good? Do you think that is a big part of what drives folks to continue to go for it?
Well, I think so. My colleague here at Harvard, Dr. Cornell West, describes it in the following way. He says that there's a pervasive sense of nihilism in young black communities. That is to say, the notion that there is no future, that there's nothing to look forward to, there's nothing to live for. And this pervasive notion of nihilism fuels self-destructive behavior. And I think Professor West is really onto something there philosophically, as that helps explain why we may engage in starkly or decidedly self-destructive behavior. I did want to pick up, if I may, on this notion of distrust too. I actually just pulled up some data and took a quick peek at a couple of the very recent studies, and the notion of distrust among physicians in black and brown communities is much higher than it is in any other ethnic community, in any other community, period. And now, with respect to the African American community, I did want to add that this doesn't just grow out of whole cloth. You see, the Tuskegee experiments, for example, is still in the lived experience of at least my parents' generation. So people grew up, like me, hearing about the Tuskegee experiments and so forth. And there is a very pervasive distrust in the African American community that is born out of the lived experiences of our parents and grandparents.
One thing I've seen that has been a powerful way amongst people who abuse opioids or use opioids is harm reduction. I don't know if we're going to get to that eventually, but harm reduction, this idea that we're trying to reduce the amount of harm, even though you're doing these potentially dangerous activities. Now, within that idea of harm reduction, you know, I first saw harm reduction really play out in a syringe exchange in Chicago. And it was there when I saw that, I recently heard somebody describe, well, they just give them needles and they give them cotton and they just give them all the materials, but they give them something else that's not tangible, which is this sense of hope that there's these people out there that care about you. And you might not have, I mean, we take for advantage all the hugs and the nice stuff that we get on a regular basis, but these individuals can get that love and acceptance for the first time. And I think that philosophy may be one tool that we have to address some of these trust issues if harnessed correctly. So,
a term we often use in different professions. I don't know how vogue it is in terms of the medical profession, but we often talk about cultural competency. You talked about with your patients, when you treat them based on their medical need, but I'm sure you're also sensitive in terms of their health history, other cultural determinants that might be playing into that. How do we, and then you also have shared that you work with a multidisciplinary team. How do we marry criminal justice with the healthcare profession and other professions that have different pieces of this issue so that we're working together and we have a better understanding of the nuances of race, socioeconomic class, education level, and access issues as well across the systems?
Well, I mean, I don't know if this would be in the medical system per se, but within the criminal justice system, I know Dr. Sullivan's done some work in drug courts as well, and I think drug court, the evidence suggests that these work, but one of the biggest failings is that there are some inequities by race and who completes these courts. So one thing that my folks that my research team have been looking at are some culturally tailored interventions. And shockingly, there are no culturally tailored interventions for African American males in the criminal justice system. I mean, that's just a shocking, given how the pervasiveness. So I think that thinking about culturally tailored, and even within that idea of culturally tailored, you know, they can be surface where you just have somebody of the same gender, race, ethnicity, or they can be, you know, deep structured where they're addressing historical trauma, where they're addressing, you know, structural disparities. So I think that's one thing in a lot of our areas that we have yet to really tap into, are designing, you know, culturally responsive in both the medical and the criminal justice world. I think we need to do a lot better job at that.
The thinking is out there. Programs are out there. There are models that exist that tell us how we might better do these things, but we need the political will to actually do them. So with respect to competence, the very first step, and it's a huge and important step, is to actually have that conversation, is to say that cultural competence is important.
Tony, if there'd been a conversation like this in the 1970s, do you think it would have affected the war on drugs?
Carmel, that is a great question. And that brings us to the Q&A portion of the town hall meeting. Among the many questions we received from around the state, the first was about the war on drugs, and a viewer asked, how do we educate law enforcement and criminal justice that the war was not effective? And if we have another war, how do we make it effective? IUPUI's Brad Ray answers first.
I do not think we should have another war on drugs.
Why do you think that?
I do not think the first one worked. I don't think that you can ever eradicate drugs from our society. And the war on drugs, however it's led, will inadvertently affect some people more than others. And in this conversation, I think we all know it would affect racial minorities more. So yeah, I don't think we can really have, and you know, the other thing is every time we talk about using the criminal justice system, I mean, I think the criminal justice system certainly plays a role in addressing this epidemic. But I think when we talk about that being our sort of main instrument, if there's somebody sitting at home that's addicted to substances and addicted to opioids, and they're thinking, if they're even getting to that point of contemplation, and they hear, well, we should arrest these people, we should not do this, we should lock them up, they're not going to come forward. That's going to be a huge deterrent. That's the type of stigma we don't often talk about. Just the policy recommendation in itself creates some additional stigma where people think, well, I'm not going to talk about that. They think I'm a criminal. They think I should be locked up. So I just don't think it's, I don't think it's the primary instrument by which we can address this problem. And I don't mean that just this opioid epidemic, but I mean substance use and abuse in general. So.
I think I agree with that. I think war is the wrong metaphor to talk about how we deal with this issue of drugs. So what happened with the war on drugs is that it only addressed one dimension of the problem, and that's why it was so successful. That is to say, the notion was we can win the war on drugs by arrests and incarceration. What they neglected to understand was that that's only one aspect of the problem. In order to deal with drug epidemics, one has to deal with the structural issues that give rise to the problem in the first place. We have to look at education. We have to look at access to health care. We have to look at provision of drugs themselves. That is, how do they get into the countries? You know, Jesse Jackson used to famously say decades ago that, you know, all these people you're throwing in jail, they don't have airplanes. They're not bringing this stuff into the country, right? So we have to think more critically about interdiction. It's a multi-dimensional problem, and if you only deal with it by, or primarily deal with it, I don't want to overstate, but primarily deal with it by incarceration of street-level dealers and users, then you're missing the vast majority of the problem.
There was consensus that criminal justice alone is not the answer to solving the problem of drug addiction. Another key component is education and the training of doctors.
Yes. I think, like, in terms of, like, not only just educating the new doctors, but we need to have people come back and re-educate other doctors. Like, I myself is a specialist, so I know how to prescribe. I have an understanding of how strong the medications are that I'm giving. I educate my patients about the medications before I give them to them, what not to take with them, how you should feel. And like I said, I evaluate my patients monthly. I think primary care doctors or surgeons, they're not comfortable with sort of how much can I give? Well, I just want my patient to feel okay. I don't want them to complain of pain, so they give them too much, and they're not there to monitor them. I think you have to re-educate about dosing, about what drug is stronger than the other. How should you dose it? How long should you dose it? When should you evaluate that patient again to ensure that this is appropriate medication?
Well, it seems like even you're an anomaly in the fact that you are having contact with your patients on a monthly basis.
Yes.
That doesn't happen for the majority of...
But for majority of good pain clinics, it is.
Right, that's what I'm saying.
Yes,
For the populations that are underserved, that's not the case.
Right, and I have a relationship with my patients.
Right.
Like, we have a relationship. I know about their families. I know what's going on in their lives. So I can appreciate when things are appropriate, like, oh, we can come down this month because you're doing much better. I see you doing these things. I sort of check off and I examine them every month.
Right.
And those are all things you have to do to assess if an opioid is appropriate for a patient.
And I will say, in terms of, like, even if we build up treatment, we need to think about how people are getting into treatment too.
Yes.
We need to decrease the barriers to it and increase the access to it and create opportunities where people can get into treatment. And so, yeah.
I think you all have answered this question, but maybe you can answer it in a different way. What is the potential negative impact on minority populations from the current response to the epidemic? So given that we now are calling it an epidemic, and I think we've kind of settled on why now we can say it's an epidemic because it's reached the majority community, what is the potential negative impact on the minority populations from now the response that is coming about the epidemic? From a public policy standpoint, funding standpoint, just in terms of people talking about it now?
So, my thought and hope and prayer is that it's going to be net positive. That is to say that we're dealing with this with a medicinal vocabulary. But you pointed out what may be some potential shortcomings. That is, will funding from federal sources and state and local sources be different as a function of different communities? Will police forces at the local level treat people differently as a function of race or ethnicity? I hope not. So my hope is that we as a country, as a culture, realize that this is an issue that impacts many people, color, culture notwithstanding, and that we ought to deal with it in a certain sort of way. But time will tell. So for now, I'm going to be an optimist and encourage all the legislators and decision makers to treat people equally with respect to this epidemic, and we'll see. And if not, then I'll file a lawsuit.
That's the American way, yes.
There we go.
This question, I'm going to give it to you first, Brad. What harm reduction tools need to be considered in order to reduce death, disease transmission that stem from drug use in minority communities, and who should pay for them?
Somebody teed that up. I'm a big proponent of syringe exchange. I know it's controversial. I understand entirely why it's controversial. But there are so many of these individuals that are dying are not being seen in any traditional treatment system. They're not even being seen by EMS. This is an outreach effort that can potentially engage people into treatment. It can reduce infections. It also, I will say too, as I mentioned, we have over 300 people dying in this county every year, and over half of those have fentanyl, right? So how do we educate people about this fentanyl? Through syringe exchange. And more than educate them about the dangers of it, there are strips that we can provide to people where they can test to see whether or not their substances have fentanyl in them. And unless we create spaces like that provide an opportunity for active users to come to get help, I think we're going to continue to see these deaths shifting disproportionately towards lower socioeconomic groups that have no access to any care whatsoever, and or seeing them continually ending up in the criminal justice system. So that's the number one harm reduction strategy I think we could adopt.
Okay.
We need to educate. And it goes right back to what Brad said. If we're not educating people, and it may come to a point where we have to have clinics with therapists and so on, people who know how to educate and who will not look down on a person for that, to make sure they understand as a productive member of society, what does that do for their children? What does it do for the wife or the husband, and so on? In that relationship, what does it do for your community? And how do you become a productive member of society? We say we want a workforce drug-free, but we are not putting the money nor actions towards that mentality.
And let me just to expand on that, this drug-free workplace stuff, we could change our mentality around that to see it as an opportunity, right? Yeah. When somebody tests positive for drugs, that's an opportunity to engage them about potentially getting help with that. So I think we can stop thinking about this drug-free and maybe seeing these more as opportunities. So, yeah.
Do you see this having more traction in more progressive communities that are on the political spectrum versus more conservative?
I think just looking across national data, we'd see that, yeah.
So what does that say for Indiana?
We need a lot of work.
Okay. I'm going to leave it at that answer. how do we train providers to be in relationship with their patients when insurance companies too many times dictate what a provider offers?
It's very difficult. So when you see a patient, you want to give them the best thing that's out there for them,
Right.
for whatever it is, treatment, interventions, medication. And insurance does, it limits, we have to do prior authorizations, or they'll say, no, they have to try this drug first before they try another one, a drug that might be ineffective. And so while we're educated to want to prescribe the best, we also know how to use the system to get what we want. And we tell a patient, we have to start you on this drug for a week, and then you can come back and get a drug that's going to work better. Or we have to do this therapy before we can do the definitive treatment. It's difficult, it's hard, and that's sort of the problem with sort of the government says one thing, we want you to do interventions and these pills and these medications which are less addictive, but insurance says, nope, you can't do that. You have to do this one, and you can't do this therapy that's going to definitively help this patient, and no, they can't do this, but they have to do physical therapy first, but nope, they can't walk because they're in so much pain, but they have to do that first before they can get an injection. It's very difficult.
We have to figure out a way where people of various means can receive the same sort of health care without undue pressure on physicians to sort of get people in and out very quickly. 15 or 20-minute increments. The physician on the panel will know much better than I, but in any human interaction, as a lawyer, as a doctor, some things just simply can't be solved ex ante. That is, in some time frame that is imposed before a visit. You just don't know. And if there are these external pressures for volume and to move people, then it gets then things get missed. So that's one issue that I would throw on the table as well.
Right. No, and it's a good one, and it leads into this question from one of our audience members. How can providers fill gaps of care when opiate-dependent individuals are no longer in care? So they're not under supervision, if you will. What can we do to fill in that gap?
I think that, I don't know if it's an education or a philosophical twist, but we need to think that relapse is a normal part of the recovery process.
Exactly. Yeah.
So when somebody does have a relapse and they're not under supervision at that time, that's not a failure. That's an event to learn from, right?
Yes.
So I think that having that philosophy, if we really believe that philosophy, I think it could change a lot of our practices and how we deal with people that have relapse while they're not under supervision.
Do you think it also can serve, unfortunately, as an incentive to going to the illegal market to get it?
If we don't accept it,
Exactly.
as, if you can't say to somebody, hey, I know you're relapsed, let's talk about it. But if you see it as just a straight failure, then no one's going to want to confront that, right? So.
And you're going to have people who are talking to each other. And that it comes back to that trust and mistrust. Who can they talk to? And, when we do not do something well, we consider ourselves failures. And the reality is, there go I by the grace of God. Each of us can fail at something.
Be thinking about just one statement or thought you want to leave with us today in terms of IMHC as it goes about doing this work and how we look at this issue. What is it that we can do, either individually, collectively, as a community, as a society, that will help to reduce the disparities that we're seeing in terms of this opiate epidemic? While you're thinking about that, I'm going to take this one last question. Someone asked, what do you think about the idea of educating middle and high school students about the opiate epidemic, going at the level of middle schoolers and teenagers to talk about this issue?
I think we're going to have to.
I'm sorry, I cut you off. Go ahead.
No, I think we're going to have to, because they are exposed to it. Whether we would like to say, no, they're not, they are. And if they are exposed, we need to be educating our children about the issue, whether they're taking, selling, or so on. Because the reality, it's happening already.
All data show that you have to talk to kids in an age-appropriate manner, but you have to. So I'll say this as a scholar who's looked at the data. Yes, I'll say it as the parent of an 8-year-old as well, that I've talked to him about drugs in an age-appropriate manner since he was able to talk, right? And as he gets older and older and older, the conversation will change a bit. But I think that you must. The cost of not doing it is way too high nowadays.
Very good. All right, so our call to action question, and your wisdom or thought for what would you leave the audience and the rest of us with in terms of our response? You first, Jocelyn.
Hope. There is hope. When things are at their worst, it is never so bad that there is not a bright, shining moment every day.
Excellent.
I think a lot of this, we've talked earlier about some of the criminal justice responses to this, but I think that while a lot of this problem is getting pushed onto the criminal justice system, I have been very impressed with some of the innovative practices locally, state level, nationally, that have been getting implemented into the criminal justice system to address this. I think we need to study those further. I think we need to develop some evidence base on them. But again, I think going back to this idea of hope, that there is kind of a mind change that's happening. So I think understanding that going forward. And then also I would say, I know it gets said a lot, but this idea of reducing stigma. Mm-hmm. And stigma is not just what you're saying and how you're saying it, but our policies can implicitly or explicitly have stigma in them. And I think we need to think about that as well. So.
I think along the lines of the stigma, I think it's important that people understand that there's a stigma to having pain or needing something to control your limitations in life, and that there are facilities and avenues and interventions that can help you, that can minimize your requirement on a pill, but that can free you and then let you do even more things, whether it be mentally or interventionally with a stimulator or an injection, or even just therapy, or just someone to talk to every month to say, gosh, it hurts to just go care for my grandkids. And you listen to them and you say, well, we can do these things to help you out. And I think the stigma of pain clinic needs to go away, and that you go somewhere that's safe, where someone can monitor how you're getting medication and that you're taking it appropriately. I think it's appropriate.
Yes. Dr. Sullivan.
So my parting thoughts is that justice doesn't just happen. People have to make things happen. So structure impacts behavior. Citizens of goodwill, people do good, have to insist that their policymakers do the sort of innovative thinking and figure out what the innovative practices are around the country. Each and every one of us as citizens have the right to insist that our lawmakers, that our policymakers do this. And if citizens engage, then the policymakers will follow.
Wow. Great way to end. Well, thank you, each and every one of you who's been on our panel, but even those who are in the audience and are watching across the state. Again, Dr. Bush, we appreciate your being here. Dr. Bray, Joselyn, Ms. Whitticker, Dr. Sullivan. Hopefully it's been insightful and you've enjoyed the conversation. Let this be the first place that we're starting the dialogue where many more things hopefully can come afterward. And it's now my privilege to turn it over to Tony Gillespie from IMHC.
Carmelo, this was a very important starting point for Indiana Minority Health Coalition. We're going to continue this great discussion with opioid roundtables around the state. For more information, go to imhc.org.
It's been our pleasure to collaborate with you on this project and to extend the impact of our journalism with community engagement. You can expect Side Effects to continue tackling important and sometimes challenging public health topics. Please look for our stories on sideeffectsnews.org. From IMHC and WFYI, thank you for watching.
This production was made possible through a grant from the Richard M. Fairbanks Foundation.